Hello, hello, hello. I hope everyone is doing well today and feeling healthy. Um, yeah, I'm gonna go live here with Joe Nice, and we're gonna talk about health. Hello, hello. Oh my goodness. Hello,
Catherine,
friend.
how are you?
I'm doing well.
I'm
How are you
I'm
doing?
I'm I'm alive. I'm alive. I'm alive and living in that order.
I mean, okay, that's fair.
In that
One of
order.
those days, I
You
guess.
know what? It's one of those lifetimes. I didn't get a whole lot of sleep last night. I'm a bit more irritable than I really should be. And then I saw the craziness today at the park again, the park being a complete absolute mess again. I decided to go ahead and clean it up again. Not the entire park, but my little spot, the areas I usually occupy,
Hmm.
because it's important for me to be responsible. And I'm going to continue to embarrass Baltimore City into doing their jobs.
Good.
That's what
And
I'm.
thank you for doing that
You're
because
very
it's so
welcome.
important.
It's important and it's necessary. And you don't even live in this country, and you're thanking me. Yet there are people who walk the park every day who are just like, you know what? Fuck it. Let me just throw a piece of paper on the floor. Someone else will pick it up. Because I feel like being an irresponsible asshole. And that's okay. That's okay.
It's not.
No,
We
no.
need to have a collective consciousness with this stuff. And, I think that that is something that a lot of people are missing.
Oh,
And it's frustrating for me.
it's frustrating for me too. But you know what? Karma's a bitch, and for every person that acts irresponsibly like that, there's going to be some bullshit that will eventually happen to them. Like their car might get keyed, or they'll forget their wallet somewhere, or they won't have enough battery in their phone to make a purchase that they wanted to make. Some bullshit will happen to them, and then they'll think about their actions when they throw a water bottle out the car window or something, or they drop that banana
I
peel on the
hope
side of the
so.
sidewalk. So it's fine. It's fine. But we don't want to wish bad on anybody. We're keeping it all positive vibes. We're keeping it plus signs here in the Joe and Cat Chat series, episode number 5. I'm happy to be doing this with you. And I think a lot of people are going to get something a lot out of this today, because we're talking healthcare. We're talking medical apartheid. We're talking the Canadian healthcare system. We're talking the United States healthcare system, and how all of that relates to the current pandemic, COVID-19. Yes.
Yeah, let's get into
Let's
it.
get into
That's
it.
great.
Let's get into it. And excuse me. And I think so many times we hear, what is healthcare? Healthcare, I have it. Um, in the United States, so much of everything we talk about is about health insurance. And I remember when I bought my first car. Actually, I didn't even buy it. My mom gave me her old car. Then she ended up buying a car. And so much of having a car or being able to drive, let me go this direction. So much of being able to drive. In order to be able to drive, you have to have a car to drive, but you also have to be insured to drive. But no
Hmm.
16-year-old ever said, hey, I can't wait to get car insurance. No one ever says that. Every 16-year-old who can afford to have a car says, wow, I can't wait to get a car. So I want to make sure that we approach this conversation from the aspect of, hey, you know what? I can't wait to get health insurance. No, because no one really wants health insurance. People want health care. It's similar to that
Hmm.
16-year-old that is chomping at the bit to get their hands on a car, but no 16-year-old is chomping at the bit to actually get car insurance. So I want to make sure that we focus on what we're actually supposed to be having, which is health care. But unfortunately, health insurance is the vehicle, to use the car analogy, the vehicle through which we actually get health care. So I want to make sure we
Hmm.
really have the proper mindset into this conversation, and again, into everything we're talking about. So we talk about healthcare. What is healthcare? Healthcare is everything that's done to make sure that our mental well-being, our physical well-being, and our spiritual well-being and our physical well-being is taken care of by those who are responsible for those aspects of our care. Typically, they're usually licensed and they're trained. So they're doctors, they're nurses, they're mental health therapists, they're physical therapists, they're registered massage therapists, they're respiratory therapists. So these are people who go to a school or some sort of other education, learning, place of higher learning to learn these particular set of skills, so people who don't have those particular sets of skills can get the help that we need in whatever aspect of help we need it for. Now, healthcare is a compound word made of two parts, two component parts, health and care. Now, typically you see this word hyphenated. I don't necessarily like the hyphenation of the word because I think health care is an amalgamation of both of those words together. So it makes sense to put them together as 10 full letters in one word, as opposed to 6 letters hyphen then 4 letters. So what is health? Health is the actual condition of yourself in mind, body, and spirit. I feel healthy. I swung a kettlebell today. I did 1,000 reps of jump rope. I did a bunch of burpees and squats and push-ups. I feel healthy. My mind is clear. My body feels activated. My heart rate is up. My spirit is elevated because my mind told my body I could do these exercises better than the day before. And it's this entire cyclical process that health goes through that mind, body, and spiritual triumvirate. And then the other part of the word is that 4-letter word we call care. 2 consonants, 2 vowels. What is care? Care is someone in charge of making sure that your physical condition gets taken care of. It's someone with that particular responsibility of making sure you, Catherine Wells, or me, Joe Nice, has what I need or what you need to be in that sound condition of mind, body, and spirit. Now, usually that aspect of care, again, goes back to a licensed professional that's responsive, that has that sort of education or that sort of skill set to take care of us. But in many instances, now more than ever, we are seeing a rapid increase in self-care. And self-care takes on many forms. Self-care can be as simple as turning off your phone for 24 hours. Self-care could be a warm bubble bath with a glass of Merlot. Self-care could be taking your dog for a walk in the park. Self-care could be a nap in the afternoon. Self-care could be that pint of Haagen-Dazs sugar-free ice cream. Whatever you need to get yourself in that place where you feel as in a proper sound mind, body, and spirit, whatever it is, as long as it is not something that is self-destructive, because that goes against the point of care. Care is to make sure that you are in a more evolved and, quite honestly, a better place than you were before you got to that point where you actually need to take care of yourself. So, again, health care, it's a compound word, and then the compound word has its own definition, and the compound word's definition is, quite honestly, greater than the sum of its parts, health and care.
Yeah, no, I totally agree with that. Yeah, that's great. Thank you.
You're welcome.
Yeah, so that actually just reminded me of sort of a story I read this morning when I was preparing to do this live with you.
Mm-hmm.
And it brings in the element of racism within the healthcare system.
I agree.
And there's a story of a man whose name was Brian Sinclair.
Mm-hmm.
He's from Manitoba.
Mm.
He was referred by his primary physician to a primary care center, so like a hospital.
Mm-hmm.
It's the busiest hospital in Manitoba. And he was sitting in the waiting room after being referred for 34 hours before dying of a treatable bladder infection. And he was only 45 years old.
Oh, it's so sad.
So, yeah, it's awful. So I think that this story has to be looked at or I guess through a racialized lens, because that man was Indigenous.
Mm-hmm.
And he died because healthcare workers in the hospital overlooked him, because they investigated this. This happened in 2008.
Okay.
So they investigated it several years later. just because of public pressure, as we're seeing with much of the movement now with the police brutality.
Mm-hmm.
And what came out was that no person in that hospital that was working who testified felt that racism was a factor in this incident.
Okay.
But there was also indicators that it actually was. So the article said that he was both visible and invisible in the waiting room because staff had identified that even though they saw him there, they made assumptions about him that were essentially fatal for this man.
Of course.
Because he was Indigenous, they assumed he was drunk.
Right.
Because he probably was in pain and maybe unkept.
Mm-hmm.
They assumed he was homeless and just sitting there because he had nowhere else to go.
Right.
Meanwhile, his doctor had actually referred him, and he died because of lack of care. So I think that when we're talking about healthcare, we have to remember that these instances where care is involved, like you say, like it's holistic. There's nothing that separates our assumptions and our beliefs and our conditioning about racism in these systems, because we're all just human and we're all just doing our jobs within the healthcare system itself. So
Agreed.
just wanted to highlight that.
Agreed. And my mother is a retired registered nurse. My Aunt Gloria, God rest her soul, she was also a nurse. My cousin Siobhan, God rest her soul, she died of a heart attack at 47, and it was completely unforeseen. She was a retired pediatric psychiatrist. One of my cousin Alan on my stepdad's side of the family is a dental surgeon. He just opened up a new practice in Washington, D.C. not too long ago. So my point in saying that is whenever you take a oath, there's an oath called the Hippocratic Oath, whenever you're involved in any sort of healthcare. And it comes from the Greek father of medicine. I think his name is Hippocrates. And essentially the Hippocratic Oath says do no harm. It doesn't say do no harm unless the person is indigenous, or do no harm unless the person is black, or do no harm unless the person is transgender, or do no harm unless the person is queer, or do no harm unless the person is a Native American, or do no harm unless the person is from the First Nations community. It says do no harm. So again, that goes back to the 7th, 8th, 9th, and 10th letters of the word health care. Care. You're supposed to care about people. Care is not specific. It's generalized. You're supposed to care about anyone that you are responsible for caring for. Doesn't matter if they're homeless, doesn't matter if they're lesbian or gay or queer or black or brown or Asian. Doesn't make a difference. You're supposed to care for these people and make sure they get what they need at that particular time.
Mm-hmm. And I don't think it's about any individual, because I know many healthcare workers as well, and my goodness, they do care.
I agree.
Of course, this is not an individual problem. This is totally systemic. And there was a comment asking if this was in Manitoba, and yes, it was.
It was.
In 2008. And so, yeah, I think that the point of me bringing this up is that it's not actually the nurse's fault necessarily. Like, it was 34 hours. Like, there was probably 2 shift changes in that time.
Maybe more than that.
It's not any individual, possibly more than that. So this is like, just going back to our chats before, like, this is a systemic issue. These are assumptions that we're making without even thinking about it. And even though you're a caring person, doesn't mean you're not racist. Like, we all have racism in us.
There are cultural biases and prejudices in all of us that manifest themselves in one way or another, and it is incumbent upon all of us to work diligently every single day to overcome those biases, because racism is a virus. It's more virulent than COVID-19, which is also what we're going to be talking about later today in today's discussion. Because
Mm-hmm.
you can eventually come up with a vaccine for a virus, whatever that virus is, whether it's the flu, whether it's COVID-19, and all the varieties of flu, horse, swine, pig, bird. We will eventually find a virus for COVID-19. But unfortunately, we haven't found a vaccine for racism. And racism continues to infect each and every one of us, white, black, whomever, whenever, wherever. And there's no amount of science that's going to help us get rid of that virus that ultimately is in all of us in some manifestation or another. So what we need to do is to work to not be racist. We need to work, just like Dr. Kendi said, to be anti-racist.
Mm-hmm.
That's what we need to do. And we need to
Yeah.
look at ourselves. We need to ask ourselves difficult questions. We need to go to the places in our souls where secrets hide. And we need to ask ourselves difficult questions about ourselves that we either don't want the answer to because we already know the answer and we're too scared to admit it, or we're too lazy to actually do the work to answer the questions that we don't want answers to. So.
Yeah, no, that's totally true. And I think that that rings so true to my journey in trying to be an anti-racist advocate and activist, because I do have to remind myself constantly, like I have to be thinking about this stuff all of the time when I'm navigating through the world, because I mean, I wasn't taught how to navigate through the world through the lens of my race, because I'm white. The world was built for me. So having to like learn and remind myself of that constantly
Mm-hmm.
is just a minuscule example of how this work just is never going to be over, and how you constantly have to remind yourself to do it and to be actively engaged in it.
Correct. Absolutely. Absolutely.
So
And in terms of that sort of active engagement, there's healthcare workers who either tacitly, explicitly, or implicitly disengage from caring for people who don't look like them. That is a form of racism. And I know
yeah.
we talked about this in, I guess, a meeting, so to speak. We said there are 6 pathways where racism harms health. One of them is economic and social deprivation. It's like, well, hey, look, you know what? I can't get a job because I have high blood pressure, or I have asthma, and my asthma prevents me from walking up and down a flight of steps or being able to perform deliveries as much as I want to, and I can't work in the same way I want to. Another pathway where racism harms health is toxic substances and hazardous conditions. We take a look at what's called environmental racism. I mentioned this on one of my signs that's in the trunk of my car, where I said, hey, look, lead paint, lead in the water. Those are toxic substances and hazardous conditions. Asbestos in insulation. Asbestos, there's a small kind of 9-inch by 9-inch tile that you see in a lot of older homes that were built in the 40s, 50s, and 60s called ACT. It stands for asbestos composite tile, ACT. It's that really ugly looking bowling ball sort of textured tile. And if you want to remove that tile, you have to set up what's called abatement. And the only reason I know this is because I used to work for a disaster restoration company many years ago doing fire damage restoration. So you can't just go in and just scrape up the tile and throw it away. You have to set up containment, and all of the workers have to wear PPE, full personal protective equipment, to make sure those asbestos fibers don't go everywhere, especially into your lungs, because it can cut up your lungs
Yeah.
horribly and really damage your respiratory system. So socially inflicted trauma is another one. Let's say you're in a neighborhood, for example, on the west side of Baltimore, where you're constantly hearing gunshots and hearing violence. And again, the environment is not only just water and air. An environmental trigger could also be sound. Could also be sound.
Mm-hmm.
Sound can
Absolutely.
heal. Sound can also be used as a weapon. My friend Steve Goodman, you might know him as a DJ named Code 9. He wrote a wonderful book about 10 years ago called Sonic Warfare. And he talks about sound being used as a weapon. And the book can be a bit academic at times. It can be a bit academically and subject matter wise dense, but it's an excellent discussion of how sound can be used to harm. If you take in a lot of major cities
That
in
reminds me.
no, okay, yeah, in a lot of major
Oh,
cities, no,
sorry.
it's okay. In a lot of major cities in Baltimore right now, in larger cities in the United States right now, we're hearing a lot of fireworks being detonated. Fireworks, and
Mm-hmm.
Fourth of July is not until this weekend, but these fireworks demonstrations have been taking place for about 5 or 6 weeks now. And I think, and again, it's difficult to sleep when you're constantly hearing boom, boom, boom at 1:30 in the morning. And I think a lot of
Yeah.
those fireworks displays that we're hearing right now is a way to get people, citizens like me and you and everybody else, used to the sound of loud noises. Why? Because those loud noises to the untrained ears sound like gunshots. And if you constantly hear them, eventually you become desensitized to them. And when I was at a protest about a week and a half or 2 weeks ago, somebody detonated fireworks. And to the untrained ear, it sounded like a gunshot. Oh, shit, what the hell? So if you are a protester who was thinking about maybe going to a protest, but then you're worried that you might get shot, you might think twice about going to a protest. So I think a lot of these firework demonstrations that we're seeing right now, I think is a covert way by police officers and governments in general to begin the destabilization of the Black Lives Matter movement. Because
Yeah.
let's not forget, in the 1980s, if you know anything about what happened with Gary Webb was a writer for the San Jose Mercury News, and he decided to do an investigation in Central America about Nicaragua and the Sandinistas, and eventually found out that the CIA was taking on drugs and the CIA was funneling weapons to the Sandinista rebels in Nicaragua. So the CIA, the Central Intelligence Agency, actually became the cocaine import agency. So then you mix that in terms of healthcare. We're going back to all of this now, into inner city neighborhoods. And then you have Joe
Mm-hmm.
Biden who comes in on the back end and writes the crime bill. You see how a lot of black and brown people got unnecessarily locked up in jail because the federal government was actually importing and implanting drugs into particular neighborhoods. So if the federal government can do that with cocaine, you don't think they can do that with fireworks? Come on.
Yeah. Yeah, that's exactly the example I was going to bring up as well, because I've seen a few posts about it recently. And yeah, like people are finding just boxes of fireworks around. And so, and these fireworks are going off all night
All night.
and keeping people up. And like you say, desensitizing you to the noise.
Yep.
Also terrorizing the folks that
Exactly.
have come from places that are war torn
Exactly.
and are refugees
Perfect.
or whatever other circumstances. And I think it's exactly right that it's probably an operation by the government and the police services to start to dismantle the Black Lives Matter
I
movement
agree.
through, through having this sort of justification because they're causing, they being the black and brown communities that they're planting these fireworks in are causing a disruption. And the other aspect of this, to bring it back to health, is these fireworks are going off all
All
night,
night.
and sleep deprivation is a huge health concern.
Agreed.
So not only are they systemically trying to dismantle the movement, but they're also literally creating a health crisis in the middle of a pandemic that's disproportionately already affecting the same neighborhoods, and so they're making it
I
worse
agree.
with all of this.
Catherine, I couldn't have said it better. Couldn't have said it better. And another pathway where racism harms health is targeted marketing. So let's say, for example, smoking. Years ago, you had the Joe Camel ads, or you'll have certain types of junk food sold in particular areas. So, for example, in food deserts, and that's going to be our next topic next week. We're talking about food next week. You're going to have a higher likelihood of prepackaged food and pre-processed foods and sodas and high sugary beverages. You're marketing in particular areas, but in other areas you won't see that. You'll have more fresh food and fresh vegetable options, or they're healthier food options. So again, racism plays into that. You also have inadequate or degraded medical care. There is a phenomenon which is called, and obviously you have food deserts, you have banking deserts. We'll probably talk about finances in another episode. But there are areas where there is no hospitals or no medical facilities in those areas. So you almost want to call them healthcare deserts, because that is in effect what they are. And it's those particular areas, going to a doctor becomes a bit more problematic because there's no healthcare facility in the area. And if there is a healthcare facility in the area, it's usually not up to standard with many of the healthcare facilities in other non-black and non-brown areas where racism becomes a factor.
Yeah, and in Canada, a lot of the information around this sort of topic is on Indigenous folks. And so, because they're primarily the most affected by inadequate healthcare and medical access,
Absolutely.
because of the history of, they were pushed out of their land and just pushed onto these reservations. And for a while, it was illegal to leave the reservation. And so medical care was just not existent.
Nope.
And a lot of these places, a lot of the reservations are outside of the major city centers. And so there are doctors that sometimes fly into these really remote areas for like a day or two a month.
Mm-hmm.
That's it.
That's it.
So, yeah, these entire communities are being systemically blocked from medical care.
Right.
Meanwhile, they're also on boil water advisories and impacted by environmental racism, in the sense that there is usually toxic industries that are near these remote areas because people don't want those things in their backyard.
Exactly.
Which is also something we can talk about another week.
Exactly. That whole NIMBY philosophy.
It's a whole thing.
Yes. And
exactly.
And Catherine, the last point you mentioned about First Nations community and water and everything else, the last part where racism harms health is degradation of ecosystems. Again, if you're constantly clear cutting trees, you're constantly having sludge from gas from vehicles and heavy machinery getting into the water system, that degrades your water, which is how a lot of these First Nations communities end up on boiled water advisories in the first place. So there's a lot.
Yeah, if you haven't,
no, go ahead.
I was going to say, if those listening haven't heard of Grassy Narrows, please look it up, because that is a Indigenous community that lives downstream from a pulp mill of some kind, and they have been experiencing toxic, I can't remember what chemical it is, but it basically it builds up in your brain and it makes you go blind, and there's lots of other really awful side effects, and it's been affecting them since like the 70s, and the Canadian government is still literally just ignoring it. They still do not have any protection, and they're all just still getting sick. So please look up Grassy
Yeah,
Narrows.
grassy narrows, grassy narrows. And I know part of what we wanted to talk about today, Catherine, is the conversation between the Canadian healthcare system, and you are in Toronto, Canada, and the United States healthcare system, and I am in the United States. So go for it and talk about the Canadian healthcare system. Give us a brief history of it, what kind of healthcare system it actually is, and I'll go ahead and talk about what we got going on here in the United States.
Sounds good. And someone commented it's mercury poisoning in Grassy Narrows. So thank you,
Yes,
Shells,
thank you.
for commenting.
Appreciate that.
I blanked. So Canadian healthcare. Oh my goodness. The forefather of Canadian healthcare is Tommy Douglas, who is a politician from Saskatchewan.
Yep.
He basically implemented a system where the federal government, or well, the government pays for a portion of your health care, and then the federal government later matched it. So it was like a 50-50 split between province and federal government. And basically they pay for all of your basic needs.
Okay.
And it's amazing. I know that there's lots of issues, but the reality of the Canadian healthcare system is if you get hurt or have an illness, you will be taken care of. There's wait time issues and all of that.
And rationing, of course, yeah.
Yeah, but you can go to the hospital and you can get taken care of, and you don't get thousands and thousands of dollars of a bill later on, which is something that would weigh on my mind. As someone who grew up in this system, I just kind of assume that if I get hurt, I can go and it's not going to be an issue, and my basic need of health care is met. But I also can empathize with somebody getting hurt and trying to weigh the options of whether they can afford to go get help. And that would be a really weighty decision to make.
Yeah.
Especially if you're not a rich person, which, I mean, there's only 1% of people in the world that are really rich.
The Canadian healthcare system is a kind of system that's called a single-payer health system, a single-payer healthcare system, where the government is the single payer of all of the medical bills and charges that are incurred by its citizens. Now, every 10 years or so, the World Health Organization does what's called a performance ranking. And this performance ranking, they take, I think, 9 or 10 different factors and figure out which healthcare system is the best in the world. Care to guess which country has the #1 healthcare system in the world?
Oh my gosh, I would probably guess one of the Scandinavian countries where they have very high taxes.
Yes.
But all of their basic needs are met.
Yes.
For the most part.
Okay. So you're saying a Scandinavian country. Okay. So Iceland, Scotland, Sweden, Norway, Finland, Denmark, one of those 5?
Yeah.
Okay.
Yeah, sure.
All right, interesting. Actually, the #1 healthcare system in the world, based upon the World Health System's performance ranking, is France. If you know anything about the French social system and French medical history and all of the legendary French doctors that have come from France, it makes sense that France's medical system would be #1. The top 5, #1 is France. #2 is Italy, of all places, which actually does make sense given Italy's medical history. 3 is San Marino, which is a microstate inside of Italy, so that actually makes sense. 4 is Andorra, which is another microstate in the Pyrenees between Spain and France, which that actually does make sense. And #5 is Malta. So again, not a single Scandinavian country there. The first Scandinavian country is 11, and that's Norway. Iceland is 15th. Sweden is 23rd. Finland is 31st. Denmark is 34th. Canada. Care to guess where Canada is on this list? And I only have the top 40 here.
Ooh.
Canada.
I mean, I'm going to guess like in the 30s.
Yes.
You've only got top 40.
It's exactly 30. It's exactly 30. The United States is 37th, one space below Costa
Okay.
Rica and one place above Slovenia. And number 39 is Cuba, number 40 is Brunei. Of these top 40 countries with the World Health System's ranking, there are only two countries that do not have universal health care or a single healthcare model. Morocco, which is ranked number 29, and the United States, which is ranked number 37. And the United States healthcare costs far exceeds all these other countries. And
Mm-hmm.
over 10 years ago, the United States, and let me make sure I'm going to keep an eye on the time because we have a 22 minutes. Because what I'm going to talk about is going to take a little bit of time to really dive into, but it's going to be
Mm-hmm.
necessary in terms of making sure we understand how the healthcare system works in the United States and how it relates to COVID-19. Now, about 10 years, actually a little more than 10 years ago, when Mitt Romney, the presidential candidate back in, I want to say 2012, was governor of Massachusetts. He was formerly governor of Massachusetts and became the senator later on. He was governor of Massachusetts, and the people of his state said, hey, Governor Romney, we need a health care plan. So Mitt Romney's like, all right, you know what? Shit, I don't know. Let me get back to you. Let me talk to some people and figure something out. So he goes ahead and consults a right-wing think tank called the Heritage. The Heritage Foundation said, hey, Governor Romney, we got a plan for you. Here's what we're going to do. We're going to go ahead and have government subsidies. We're going to go ahead and create access to insurance by making sure more lower income people get access to a state managed system. Oh, and we're going to have a fancy rule that makes sure that everybody has to pay into the system. And if you don't pay into the system, you have to pay a penalty to the government for not paying into the system. So on a state level, because there were cost controls implemented and there was basically one single way to get health care on a state level, people loved mass care, or what was pejoratively called Romney care, which is part of the reason why Mitt Romney eventually became the Republican nominee for the presidency in 2012, because he had a really good health care plan on the state level. Candidate Obama said, you know what? This Romney care stuff looks pretty good. How about I nationalize it and make a couple of changes here and there? So he goes ahead and nationalizes it, and that essentially became the Affordable Care Act. Now, the Affordable Care Act on a federal level has three component parts. The three component parts are government subsidies, access to insurance, and a fancy rule called the individual mandate. Now, for the purposes of this discussion, don't worry about the government subsidies because there's different payment levels in terms of income for government subsidies. And don't worry about the access to insurance came through the Medicaid expansion, and that's a whole other several minutes we could spend talking about the Medicaid expansion. But what we're going to focus on is the individual mandate. Now, the individual mandate is a fancy rule that says you, private citizen, has to buy a privately owned product. And if you, private citizen, do not buy this privately owned public product, we, the public or the government, will assess a penalty to you for not buying that privately owned product. Okay, sounds weird, but okay. But let's take it in another way. Let's say, all right, I've got a roll of tape here. I got a roll of duct tape here. All right, and it's black duct tape. Let's say the federal government said, hey, Joe Nice, you're only allowed to buy gray duct tape. And if you don't buy gray duct tape, we, the government, will assess a penalty to you for not buying gray duct tape. Well, what if I want black duct tape? Nope, can't do it. Gotta buy gray duct tape. Now imagine if that were the case. People would be screaming in the street saying, what do you mean I'm forced to buy this product? But because it's health insurance, this intangible, nobody really said anything about it. Sure, there were some people who were like, nah, don't do that shit. You shouldn't be forced to buy something. But that's what happened. So the reason why more people signed on to the Affordable Care Act is, quite honestly, more people were forced to buy into the system. And the way insurance works is if you have more people buying into the system, it reduces the amount of risk. It's a shared risk among the greater of the population, or the aggregate, to use an insurance term. So as a result, the premiums decreased a little bit. So now part of the other leg to this three-legged stool model, and one of my old professors, Professor Mark Hall, he's one of the foremost healthcare law and policy people out here. He said, essentially the healthcare model is a three-legged stool model: access to insurance, government subsidies, individual mandate. Now, how did more people get access to insurance? More people got access to insurance through the Medicaid expansion. Now, essentially, the Medicaid expansion is, hey, federal government, we have a whole lot of money to give to the states. All the states have to do is accept a Brinks truck full of money to take care of your state's needs. And oh, guess what? We, the federal government, will pay 90% of your health care costs. And all you got to do is pay the 10%. That's all you got to do. Pick up 10%, that's it. We, the federal government, will take care of the other 90%. So even if you don't want it, all you have to do is basically pay 10 cents on the dollar and you've got it. And as of right now, 36 states and Washington, D.C. accepted the Medicaid expansion. 14 states in the United States did not. So how does the Affordable Care Act affect the people in the states that did not accept the Medicaid expansion? Here's how it works. So in the Department of Health and Human Services creates what's called the federal poverty level. And the federal poverty level is based upon an individual. And I actually have the number written down here because the number changes every year. The federal poverty level is $12,760 for an individual. $12,760 for an individual per year. That's income. Okay? 12,000. That's basically nothing. Kaplan, it gets worse because it's going to get real deep. Now, $12,760 for health insurance. Now, when the Affordable Care Act got passed, states through the Medicaid expansion were required to provide Medicaid coverage for everyone ages 18 to 65, adults, and then that was through incomes up to 138% of the federal poverty limit. So 138% of that poverty limit of $12,760 is equivalent to $17,236. So if you lived in a state that did accept the Medicaid expansion, anybody that had an income from zero up to $17,236 got covered. Great, you got covered. So that's how more people got insured through the Medicaid expansion, because it raised the maximum salary allowed to qualify for Medicaid from 100% of the federal poverty limit to 138% of the federal poverty limit. Does that make sense? Perfect. Now, also, it's still crazy, but this is how the law worked. Now, also on this,
it's still
from the government subsidies perspective, which was the second leg of this three-legged stool model, what it did is the law also provided premium tax credits from anybody that made between 100% of the federal poverty level salary, which is that $12,760, all the way up to 400% of that federal poverty limit, which is equivalent to $51,040 for an individual. So if you made between 100 and 400% of the federal poverty limit income-wise, you were also eligible to receive tax credits to buy Obamacare, basically. Okay? Now, there's a phenomenon that took place in the states that did not accept the Medicaid expansion, and it's called the coverage gap. Now, this is a rather insidious situation that was placed upon many of the citizens of the United States, because for incomes that were at 100% or below the federal poverty level at $12,760, the problem was there was people who were making too much for Medicaid on the state level, but not making enough money to buy health insurance plans through the state exchanges. So in the states that did not accept the Medicaid expansion, if you had a salary, the maximum amount of salary earned under Medicaid, which is actually $8,532 per year. So if you made $8,532, if you made more than that, but less than $12,760, which is 100% of the federal poverty limit, that gap in between salary-wise is the coverage gap, where you make too much money for Medicaid, but not enough to begin to get the government subsidies. And that is where health insurance, and you can't go through the state exchanges to buy it either, so you have to go to the private market, where health insurance gets impossibly expensive. So why does this coverage gap matter? Because most of your service workers, most of the people who are most vulnerable right now in COVID-19 fall primarily in that gap. They also fall not necessarily in this coverage gap, but they might fall within that gap of not necessarily getting health insurance through their employer. Their employer may not offer health insurance. So if your employer doesn't offer health insurance through a group plan, because again, with a group plan, you end up spending less money because there's more people paying into the plan. What you eventually have happening is you can't go through the state exchanges to buy insurance, so you have to go outside of the state exchanges to the private market. And the private market, that's where health insurance is through the roof. So if you're making, it's so much money. So let's say you're making $11,000 a year in salary.
So much money.
Okay, you make too much for Medicaid, and you don't make enough to qualify for the government subsidies. What happens then? You're going through the private. You go through the private insurance exchanges, not through the state, but the marketplace. And at the marketplace, for a cheap plan, you're paying maybe $600 or $700 a month. Where are you getting that kind of money from if you're only making $11,000 or $12,000 a year? That's not happening. So going back to the third leg of the whole situation, the individual mandate, with the individual mandate, if you didn't buy health insurance, you had to pay a penalty. And the penalty was a $695 penalty for an individual or a $2,000 penalty for a family. Yikes. So when President Trump passed the Republican tax plan about a couple of years ago, he knew he wanted to repeal the Affordable Care Act, but he couldn't get the votes. And he wasn't going to get the votes legislatively through repealing the Medicaid expansion because that's just way too much work to sue all the states. And revoking access to insurance, no, the people already took the money in the form of block grants for billions of dollars per state. No, can't do that. So what did he do? What he did was, okay, well, I can't repeal the entire law, but I can pull a leg from this stool and essentially make this entire stool collapse under itself, or at least have it wobble a little bit so it's a bit more tenuous. So what did he do? He didn't repeal the individual mandate. He just made the individual mandate $0. So if you were a indigent person, basically a person without any sort of financial resources, and you said, yo, you know what? I'm not buying health insurance, and guess what? I don't have to pay a fine for not having health insurance. Okay, you're good to go because there's a $0 individual mandate now. So what happened with that, and how, again, it relates to COVID-19? What happened with that now is you have a whole lot of young, healthy people and young, poor people who aren't buying health insurance. You also have, and again, insurance works best when more people pay into the system. So now you have fewer young, healthy people paying into the system. You have more poor people that have opted to not buy insurance. So now people who want insurance and people who need insurance, and based on actuarial science, old, sick people who aren't at age for Medicare because they're too young to get on Medicare are paying through the roof now because the premiums have gone up because there's no more individual mandate that's basically a giveaway to the health insurance companies to make sure that citizens pay into the system. It's completely skewed the market. On top of that, people who now want health insurance now have to deal with a phenomenon called junk insurance. So the health insurance companies know that they're not going to get any sort of money from everybody as they used to do because of the individual mandate. So now what health insurance companies have done is raised deductibles, raised premiums, and raised co-insurance penalty percentages. So now, before the individual mandate, you had deductibles of maybe $500 to $1,000. Now you're having deductibles that are $5,000. and co-pays that used to be $250 are now $500. So essentially, you, the individual, are insuring a lot of your own health care that that health insurance companies used to insure as a result of premiums that were paid to the health insurance companies. It's an absolute mess right now in the United States.
Yeah. Oh my gosh. So that was actually really enlightening. Thank you
Mm-hmm.
for going over all of that because I knew like a little pieces of all of
You're very
that, but
welcome. You're very welcome.
you put it together in such a succinct way, so I appreciate it. Thank you. Um, yeah, it clarifies a lot. Yeah. Oh my gosh. So yeah, that means there's a lot more vulnerable people
Correct.
in our current state, in the
Absolutely.
sense that like the world has a pandemic going on still. So what's your thoughts on the pandemic, this COVID-19, and all of the increased vulnerability that this system has, like the crumbling system, I should say, is perpetuating, and yeah, like what's your thoughts on
Well, Catherine,
how
here's
these
the
people are
biggest
gonna
part of it is there's a lot
continue?
of people that aren't continuing because they're dying. And they're dying because of the inequities and inequalities that are baked into in the Affordable Care Act. Because the Affordable Care Act never said everybody gets insurance. The Affordable Care Act, one of the pillars of the law is access to insurance. That means you have the opportunity to get health insurance if you're willing to pay for it. Unlike you in Canada, you get health insurance simply because you were born in Canada.
Mm-hmm.
So there's a big difference there. Now, again, with the racial
Yeah.
wealth gap as it is, and in a lot of the cities that have a lot more service-oriented work, and in these cities where there's a higher concentration of service-oriented workers and a higher concentration of communal living in large apartment buildings and apartment complexes, and you also have those people who live in these large buildings or large apartment complexes are less likely to have their own transportation. So naturally, they're going to be using public transportation more often. So you can't effectively social distance because you are using public transportation. You are working in a service-related industry where the pay is low and the employers may not necessarily be keen on providing you with the PPE that you actually need, or something as simple as hand sanitizers and masks. Additionally, you have, especially in the undocumented worker community, and of which there is a larger community, there tends to be a lot more communal living in small spaces. You might have an apartment that might have 2 people on the lease, but you might have 6 or 7 people staying in the apartment. And if you have 6 or 7 people staying in a 2-bedroom, 640 square foot apartment, social distancing becomes a bit of a problem. So the healthcare system of the United States, in addition to the racial wealth gap, has created this massive inequity during the pandemic that is becoming more and more prevalent and more obvious. Because if you have jobs where you are able to work from home, non-service oriented jobs where you're able to work from home and you can effectively social distance because all you need is an internet connection and a fancy ring light to do a Zoom meeting and you're still getting paid, you avoid a lot of the health problems that are being caused in a lot of major urban areas right now because you can effectively social distance and you can quarantine. You don't have to be around people. And if you have one of these jobs where you don't have to be in a service-oriented type of industry, guess what? You're probably getting paid more and you probably have better health insurance to begin with. So the racism, it's
Yeah,
it's
exactly.
this sort of health apartheid. It's a catch-22 caught between a rock and a hard place. It's, well, wait a minute. Well, these people who are primarily black and brown are working these lower waged, either underinsured or uninsured health insurance wise jobs, and they can't effectively social distance. They're using public transportation. They don't always clean the public transportation systems,
Mm-hmm.
and they're low, and they're either uninsured or underinsured. And then on the flip side of it is, okay, well, you know what? You have a whole lot of white folks who have higher wage jobs, better access to health care, better health insurance. They can effectively social distance. They have higher wage jobs. And if there's a medical emergency that takes place, they're more likely to deal with the aftermath of dealing with the medical emergency because they had the financial resources to deal with the medical emergency, as opposed to the black and brown person or the Latinx person who may not necessarily have the same financial resources because of the job in which they work, the institutionalized racism that has been we've been dealing with generationally, and healthcare tied into all of that as a result of where they live, the job where they work, and their socioeconomic status.
Yeah, that was an amazing roundup, and that's exactly where my mind went to, is like these conversations that we're having around
Agreed.
essential workers. These are precarious jobs for the most part, and I mean, these issues are in Canada as well. We have healthcare, but the systemic issues that we've been talking about on all of our
Ties together.
chats, there you can see now how all of this um, is sort of, it ties together. It's intersectional. This is like why, we're doing these chats the way we are, because we're trying to reveal how all of these things are interconnected, and really contributing to this messed up system that we have. And one thing that I wanted to mention is, although in Canada we do have sort of the universal healthcare system, but the program that we have for temporary foreign workers exempts those people from our healthcare. So there are major issues with
Yes.
temporary foreign workers right now, which primarily in Canada they come from Mexico, and they're
Yes.
here for they work on farms for the summer, and they usually travel
Hmm.
between the regions of the country throughout the summer season, picking and helping on farms. And
Hmm.
these conditions that they're living in are deplorable. And so there's been
Of
lots
course.
of outbreaks of COVID-19 throughout different areas of Canada with these temporary foreign workers. And of course, they don't have the same access to healthcare as a citizen would. So yeah,
Absolutely.
it's an issue
Catherine, how much time do
everywhere,
we
and
have left, if you don't mind me
we
asking?
need to be paying attention to this stuff for
2 minutes left?
sure.
Okay, 2 minutes left. Okay. All right, because I've been keeping a timer on my
We only
side,
have two
so okay,
minutes
just so
now.
just so I know. So we have about 2 minutes left.
Yeah.
There's one other aspect that I wanted to bring up, and I'll try and summarize it in about 30 seconds. Another reason why
Mm-hmm.
people of color, specifically black people, are having more of an issue dealing with COVID-19 is because of a phenomenon called the Tuskegee effect. Now, if you know anything about the Tuskegee experiment, these were experiments taking place in Tuskegee,
Mm-hmm.
Alabama, where many black men were injected with syphilis, and they weren't told they were injected with syphilis. Many of them died, and it became just an entire mess after that. So in the black community, there is a historical distrust of not only going to the doctor, but for black people going to white doctors. And there's a lot of black people that will just eschew medical care simply on the basis of
Yeah.
not feeling as if they can trust a white medical professional. So again, we talk about all this stuff, but one of the solutions that I think we actually need to have, and again, we talked about community policing. I certainly think that having community health care would be an issue. Because let's face it, you're a white woman, white women's health care needs are going to be different than a black man's health care needs. And if you're in a particular community, for example, a First Nations community, or a Native American community, or a Latinx community, your healthcare needs are going to be different. So representation within those particular communities of healthcare is going to play a difference in the outcomes that you're going to have in those particular communities. Yes, ma'am.
Yeah, that's so true. And I wish we could talk about this
You're very
forever, but
welcome.
we're running out of time. So I want to thank
Absolutely.
you so, so much again for continuing to do
Absolutely.
these chats with me. Um, we're going to keep
Yep.
doing them for everyone that likes them and wants to see. Next week, we're going to probably continue this conversation and move into food security.
Oh,
and so that's, food,
it is
all
part of
things
health.
around food.
And again,
which,
real quick, in about 10 seconds, I want everybody to look up food desert, food swamp, and food oasis before we start next week's conversation. Look up those three terminologies, and we're going to